Good evening, everyone, and welcome to the National Pancreas Foundation's virtual education webinar. I'm Trish O'Neill, the National Director of Chapter Development. The mission of NPF is to provide hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Partnering with over 160 centers of excellence throughout the U.S., some of our featured programs include the Animated Pancreas Patient, the NPF Cookbook and Pocket Guide offered in hard copy and as a free download, the African American Initiative, our patient registry, state chapters that support education, fundraising, and patient support, and our physician programs that include research grants, medical education, and our annual Fellow Symposium. Our success depends on the support of many individuals and organizations. Please consider taking an active role in furthering the mission of NPF by sharing your personal story, making a donation, or starting a chapter in your local community. Our next virtual webinar is this Saturday, April 29th, with our Michigan chapter and the University of Michigan Health, covering topics on diabetes in pancreas patients, maldigestion, and hereditary pancreatic cancer. To learn more, visit pancreasfoundation.org. Our topic this evening is biomarkers and liquid biopsy for early detection of pancreatic cancer in 2023. Tonight's session is presented by NPF Center of Excellence Medical Director, Dr. Rosario Lagresti from Hackensack University Medical Center, and Laura Suggestion Campbell, Vice President of Clinical Medical Affairs at Immunovia. Please use the Q&A section of this portal to submit your questions, and they will be answered at the end of tonight's presentation. Dr. Lagresti is the Division Chief of Gastroenterology at Hackensack University Medical Center in New Jersey. He is also the Academic Chair of Gastroenterology for Hackensack Meridian Health and an Associate Professor of Medicine of Hackensack Meridian School of Medicine. Dr. Lagresti trained at New York Presbyterian Hospital for Internal Medicine, Gastroenterology, and Advanced Gastroenterology. He currently directs the Hackensack Meridian High Risk Pancreas Cancer Surveillance Program. Dr. Lagresti has served as the medical director of the New Jersey chapter for the National Pancreas Foundation since 2019. His practice is dedicated to the interventional endoscopy with a special interest in the early detection and treatment of gastrointestinal malignancy. Thank you both for being with us this evening and sharing your professional knowledge and expertise on this important topic.
Great, thank you, Trish, and welcome. This is a great event, I think, because it really gives us a glimpse into the future of pancreas cancer detection and hopefully ultimately pancreas cancer treatment. So we'll break the talk, the talk, and it's going to be spanning over about an hour and 15 minutes. We'll break it off into two sections. What I'll do with the initial part of the presentation is we'll talk about kind of the global landscape and how exactly do these new technologies fit into the screening algorithm for pancreas cancer. So where exactly do biomarkers fit in the early detection of pancreas cancer in 2023? Basically, we don't really know yet. You know, are they a diagnosis? Are they a distraction? And is it all just wishful thinking? By the end of this talk, I think you'll have a very clear understanding of where the field is and where the field is going. This is, again, a topic that's been on a lot of people's minds for quite some time. I'm sure lots of people in the audience remember the Theranos disaster from about 10 to 15 years ago. Elizabeth Holmes became a very, very rich woman with the claim of just one drop of blood, they can test for 30 diseases. And I think she kind of brought the idea to the forefront way before her time. And now, despite the fact that her entire idea was a little bit of magic, now the idea has actually gained steam, as you'll see as we go along. But the idea has been around for quite some time, and I'm sure lots of people in the audience remember Bones from Star Trek, and he used the tricorder, and again, it was a non-contact way to diagnose any disease. But even he was a little bit of a realist, and this quote is probably one of the most famous quotes in Star Trek lore: "Damn it, Jim, I'm a doctor, not a magician." So is screening for pancreas cancer even worthwhile? And to answer these questions, we're going to be basically going into what exactly makes pancreas cancer a perfect candidate for a screening test of any kind. The most important thing with pancreas cancer and why screening is worthwhile at all is, as you can see by these statistics, the extremely poor survival of the disease. The deaths and kind of basically come very much the same as the estimated new cases. And despite the fact that the 5-year relative survival has increased from when I first started doing this about 20 years ago, of about 5% 5-year survival, we're now up to 11.5% 5-year survival. It's still obviously a crummy diagnosis for both patients and caregivers. And the reason why that is the case is it's most likely to be diagnosed late. If you look at SEER data that's been put out yearly, and this is the most recent data, most of the percentage of cases by stage, most of the disease is presented as a very, very distant or metastatic stage. So 52% of patients have metastatic cancer, and obviously that's a very, very poor outcome at the get-go, at presentation. Very, very few patients present with localized disease. The pancreas is kind of a very quiet organ in the body, and unless there's something in just the right spot in the pancreas, most patients don't know that they have a tumor. So by the time they actually have symptoms, most of the time it's already too late. And survival then correlates with stage. As you can see, the 5-year relative survival for patients, if they present with localized disease, is pretty darn good. That's 44%. Unfortunately, nobody presents with localized disease, and everyone presents with regional or distant metastatic disease. And you can see there that the survival drops precipitously as the disease becomes more and more outside of the pancreas. More importantly, or just as importantly, pancreas cancer is a very expensive disease. And you can see there both the direct and indirect costs of pancreas cancer are broken down into all those different pie slices, from medications to hospice care to being in the hospital, to nursing home care, to physician care. All of this in one recent estimate amounts to about $4.5 billion annually. And that's probably underreported as far as the total amount of money that pancreas cancer patients and patient care will ultimately spend on the system. The other thing that's just as shocking, and not just the cost and the stage-related survival, but the fact that the incidence of pancreas cancer is increasing dramatically worldwide. One estimate puts pancreas cancer at probably the number 2 cause of cancer-related death and/or mortality by 2030. And you can see these numbers are kind of bad, especially since the graph is going up every single year since 2008. And we don't really have a good understanding as to why that is, but it seems to be increasing the most and the fastest in female patients. Now, if you looked at all those slides, you would basically come away from this talk saying this is pretty fatalistic, and why the heck are we thinking about screening? It's kind of like a crummy disease. Patients really can't be found at a very early stage anyway, and by the time anyone is diagnosed, it's too late, so why the heck are we doing any of this? As it turns out, biologically, pancreas cancer has a very long period of time for cancer development. I won't go into the very nitty-gritty details of this slide, but essentially, going from left to right on the screen, you could see from normal pancreas cells all the way to invasive pancreatic ductal adenocarcinoma, there's an entire pathway that has to kind of go through. Very much like going from a benign polyp in the colon to colon cancer, there are multiple steps that cells have to go through before they become pancreatic cancer. And this was kind of a little bit of a shocking paper that came out in 2010 in Nature by Yoshida's group. And what it showed was, again, there's a very long period of time for the cancer to start from a cell and end up with metastatic cancer in the patient's death. And that was estimated in this mathematical model to go from anywhere between 10 and possibly 15 years from when the cell goes bad all the way to invasive malignancy and patient mortality. So there is a very, very long period of time, again, going from left to right, where theoretically, if some test existed, you can intervene and potentially cure the patient. This was another model that was published in 2012 by a pathologist at Memorial Sloan Kettering, and they too came up with a very, very long period of time from initiation changes in the pancreas all the way to cancer, and then ultimately metastatic disease. As you can see there, we're looking at a 10 to 15 year period. So that window provides an excellent opportunity for some tests to potentially come in nice and early in that pathway, if it's possible to detect cancer at that point, and then intervene and potentially cure the patient way before you get to the metastatic disease stuff on the right hand of the slide. So if you kind of stop and think about it, okay, there's this great window of opportunity. The disease is terrible. Pancreas cancer will be a perfect cancer to apply to a screening protocol. But then you have to kind of sit back and say, okay, does screening even work at all? And it turns out there have been two large trials, one by Clatty's group in 2022, and they published the results of a 20-year prospective cohort surveillance study in 347 patients with a particular mutation that generates pancreatic cancer. And in this study, about 83% of these 36 individuals that developed pancreas cancer in that trial were diagnosed at a resectable stage. Again, keeping in mind that that's not the norm for pancreas cancer generally. So 33% of those patients were found at stage 1. And if you remember earlier, very few patients in normal clinics are found at stage 1. And in this particular trial, the median survival was 27 months, and the 5-year survival wasn't 11%, but it was actually 32%. So alarm bells were starting to go off, and people were thinking, hey, this actually could work. And in Lou's meta-analysis trial, they looked at 16 studies of surveillance that had been published up until 2015, and they found that patients who were in a surveillance program had higher curative resection rates, higher 3-year survival rates, and higher detection rates at an earlier stage. So again, early signs that this could be a home run. So is screening for pancreas cancer in the average patient anything we won't even want to think about? This is the average risk, the average lifetime risk of developing pancreatic cancer in the standard patient out in the street, Mr. John Smith, who never had any history of anything, doesn't have a family history of pancreas cancer, and just kind of walks in the door and says, I think I might really want to be screened for pancreas cancer. And you kind of have to tell him what his risk is. In this case, his risk is about 1.5%. So that would be considered too low to want to invest a lot of effort into try to find pancreas cancer in that patient, just kind of the average patient. And in fact, the U.S. Preventive Services Task Force, or the USPSTF, recommended strongly against screening for pancreas cancer in an asymptomatic adult, so the average person. And this was published in JAMA in 2019 by Owen's group, and they basically said, don't screen the average patient because the risk is just too low. Pancreas cancer, thank goodness, is still not a very common cancer. So then who should we screen? Well, it really depends on the overall risk, especially genetic risk. As you can see on this slide, there are lots of reasons why patients could develop pancreas cancer based on genetics. And we do know that obviously pancreas cancer is seen in families. And you can see there on the left, familial pancreatic cancer increases your risk of developing pancreatic cancer substantially as the number of first-degree relatives increases. Such that if you have 2 first-degree relatives, the relative risk can increase from 1.5, as we saw earlier, to up to 18. So the risk of developing pancreas cancer by the age of 70 is about 3%. Then there are various other genetic conditions, which we'll talk about in a little bit more detail as we go on in the talk. And as you can see there, that's the mutation that was looked at in that surveillance trial, the familial atypical multiple mole melanoma, driven by a gene called CDKN2A, or P16, and the risk of developing pancreas cancer in that population by the age of 70 was about 20%. And then there are various other diseases that we look at, for example, cystic fibrosis, or HNPCC, or hereditary non-polyposis colon cancer, driven by those mutations that you see on the screen, MLH1 and MSH2. Again, these are diseases that increase risk. So these certainly are patients that certainly should be involved in a surveillance program at a high-risk surveillance program center. And then there's all these other things that could cause pancreas cancer that we know of. Everything on the bottom of the screen is potentially protective against pancreas cancer, but everything at the very top of the screen are entities that are affecting patients both in the environment and also within their own bodies that potentially can drive pancreas cancer. And the more triangles you have there on the right, the more the risk is increased. So cigarette smoking, being exposed to radiation, things like periodontal disease, all these things kind of increase your risk for pancreas cancer. And ultimately, we should keep these disease entities in mind if we want to pick up a screening population to look for risky pancreatic cancer. There's a special case certainly for new onset diabetes. As you can see in this graphic, there's a very large segment of the population there at the bottom that develops new onset diabetes. And that's diabetes that, again, there's no family history, there's no antecedent history, and you develop diabetes by the age of 50. And again, no particular good reason why you should have it. Of that group with new onset diabetes, about 1 in 100 people are diagnosed with pancreatic cancer within 3 years of their diabetes diagnosis. And 1 in 4 people diagnosed with pancreatic cancer were first diagnosed with diabetes. So it's kind of a little bit of a symbiotic relationship. Diabetes is probably, or new onset diabetes is probably a clinical biomarker for the development of pancreatic cancer, but probably developing new onset diabetes may drive the development of pancreatic cancer. So it's kind of a special case, and we are certainly looking at patients with new onset diabetes for screening purposes. So are there any tests that can detect pancreas cancer early? And as you can see here, there's certainly a number of tests that are out there. We know we can image the pancreas quite beautifully with both CAT scan, MRI, endoscopic ultrasound, which I'll show you some images of in a few minutes. And then there are various biomarkers or liquid biopsy tests that include blood tests and urine tests and breath tests and stool tests that can detect pancreas cancer. And we'll talk about all of those in a few minutes. But certainly the mainstay of how we look for pancreas cancer in patients is by imaging. And imaging has evolved over time, but imaging remains still the gold standard for looking at the pancreas. And we know we can see the pancreas very, very nicely. At the very top of the list here, that will be standard abdominal ultrasound. We don't really use that very much. You don't see the pancreas very well on a study like that, and that's kind of limited by a lot of gas in the abdomen. Again, ultrasound doesn't go well through gas, so that's really not so good. And the only good part about ultrasound is that it's cheap and easy to do, but the sensitivities, as you can see there, aren't so great. CAT scan, the downside with using CAT scan is the radiation. So you really don't want to use CAT scan on patients every single year, but CAT scan is still the primary imaging modality for pancreas cancer diagnosis and for evaluating whether tumors are resectable and also to evaluate whether patients are having a good response. Again, the downside is why wouldn't you use it every year? Because every single year, then you'd be blasting patients with radiation. And that's probably not good, as we saw on the slide earlier, and that radiation can cause pancreas cancer. So that may not be a good tool for just routine screening and surveillance. MRI certainly is one of the best tests for imaging the pancreas. And you can see there the sensitivity is pretty darn good. It picks up small tumors very, very nicely. It's easy to do for patients. Generally, again, it's got some issues with patients who are claustrophobic or they don't like holding their breath for 10 minutes. So it's got some issues certainly with doing MRI, and without a doubt, it's expensive, but certainly a good test for annual use. Endoscopic ultrasound, kind of the bread and butter of pancreas evaluation testing that I do every single day, is very, very good. It allows you to do biopsies of any part of the pancreas very, very readily. The downside is that, as you can see there, it's invasive. And more importantly, operator dependent. I mean, you have to kind of go to someone who does a lot of endoscopic ultrasound because a lot of the imaging is based on experience evaluating those images. They're kind of dynamic images that are appearing in real time. And you can make certainly things that are not tumors look like tumors very, very easily. So you've heard, obviously, it's all over the news and all over the internet and all over newspapers, artificial intelligence. And we're just beginning to see where artificial intelligence may actually help doctors. The majority of published papers with artificial intelligence in pancreas cancer shows that artificial intelligence is very useful, not at necessarily finding pancreas cancer, but at distinguishing pancreas cancer from other things in the pancreas, specifically chronic inflammatory things like chronic pancreatitis. Sometimes, again, just a radiologist looking at a CAT scan may say that something is a tumor when it's chronic pancreatitis, or vice versa. The best models that have been published for artificial intelligence-assisted imaging show about 95% accuracy. Kuwahara's group in 2019 showed that a deep learning AI system could predict cancer with an accuracy of 94%, which was higher than any prediction obtained using endoscopic ultrasonography, and better than the doctor, as you can see there, substantially. Doctor would say something is or is not pancreatic cancer 56% of the time, and the AI was at 94% of the time. So again, pretty amazing. But then the study came out in 2021 that kind of blew my mind from Qureshi's group, and they showed that an AI-enhanced CAT scan could predict the development of pancreas cancer 6 months to 3 years ahead of time with 86% accuracy. So that's pretty incredible as far as I'm concerned. This is a patient who has no symptoms, gets a CAT scan, the robot reads it and says, I think you're going to get pancreas cancer in 3 years. And the robot is right 86% of the time. Pretty amazing. And that's, again, we are just at the very, very beginning of that field. So what does a CAT scan and an MRI look like? You can kind of see here, this is very helpful when there's a nice big cursor surrounding the tumor. The one on the image on the left is a typical tumor in the head of the pancreas. The pancreas is kind of that gray sausage down the middle there, between the liver on the left and the stomach on the right. Obviously, the big thing with cursors around it is the tumor. A comparable MRI image on the right-hand side of the screen looks kind of similar, kind of picks up different types of features that a CAT scan does or does not pick up. Endoscopic ultrasonography, this is a typical image that we would see of that same kind of tumor. And you can see there, it's kind of this rounded, darker lesion. You can see, again, cursors around it. And you can do biopsies, again, of this relatively easily. And more importantly, if you could do biopsies, you probably can inject stuff into this. We just don't yet have a good thing to inject into it to potentially do treatment. So now we'll talk about really where we are going with biomarkers. So first of all, we need some definitions. So what the heck is a biomarker? A biomarker is defined as any substance, any structure, or any process that can be measured in the body or its products and influence or predict the incidence and outcome of disease. The majority of biomarkers are identified in blood or serum. Biomarkers are present, if at all, at very low levels, and the signal often needs to be amplified. So what's the biomarker history in pancreas cancer? And this goes again back to 1954, where Fabiano and Cavallo postulated on the use of, quote, chemical blood tests for the early diagnosis of pancreas cancer. So people, were thinking many, many years ago that maybe there's something in the blood that could be checked for that will predict whether or not patients either have pancreas cancer or potentially will develop it. CA19-9 was discovered in 1979 by Koprowski's group, and between 1984 and 1986, CA19-9 was found to be elevated in 76% of patients with pancreas cancer by Hagelin's group. And CA19-9 remains currently the only FDA-approved biomarker for detecting and managing pancreas cancer clinically. And you can see there, that's one of the first papers that evaluated this tumor marker for pancreatic cancer detection. So what are the hows? As you can see here, we talked about some of this progression. When pancreas cancer cells, and you certainly don't need to dive into all the details of this busy slide, but when pancreas cancer cells develop, stuff kind of gets secreted both in the body and out of the pancreatic cancer cells that results in lots of things happening in the body. And then these different things that get shed out of the cells or potentially shed out of immune system response cells are detectable in the blood. And you can kind of see there at the very bottom, that C area, lots of things are found in the blood that are associated with the development of pancreatic cancer, both alterations in the cell, alterations in the body. Things are happening there in the soup that's considered blood or serum that potentially are detectable by a test. And as you can see here, we really are comparing all of this stuff with standard tissue biopsy. So what's the problem with tissue biopsy? Obviously, it's invasive. It's difficult to repeat for some patients. It's got time costs. It's got true costs. Again, it's got a high sensitivity because, again, if you're biopsying a tumor and you get a result, that's helpful. But again, it's still an invasive test. What about liquid biopsy? Well, it's minimally invasive. It's just a blood test, potentially. It's repeatable. There's certainly less cost in obtaining it. And as you can see there, lots and lots of things have been looked at, and we'll talk about that in a few minutes, of what can be tested in the blood and in other different parts of the body to come up with potentially a diagnosis. And as you can see here, this is another schema showing a little bit of what's been available currently, and I'll go into some of these things in a little bit more detail. There are the traditional tumor markers, which we just talked about, CA19-9, metabolites, there's DNA just floating freely in the blood. There are antibodies, again, measuring the body's response to tumor. There's RNA kind of freely floating, called microRNA. There are inflammatory factors, there are circulating tumor cells, and then there are various proteins circulating around, all of which potentially could be measured in the blood. But let's just go back for a second to what CA19-9 is, because again, this is kind of the granddad of all the biomarkers that are out there. That's kind of what CA19-9 looks like. In a schema on the right there, you can kind of see it's kind of like a big sugar sign hanging on the edge of a cell. So what's CA19-9? It's a cell surface glycoprotein complex, and it requires the Lewis gene product, which is a gene product from red blood cells. The problem is that this gene product that's that's useful for the body creating CA19-9 is not present in 6 to 22% of Caucasian patients. So 6 to 22% of Caucasian patients don't even produce CA19-9. It's produced by ductal cells in the pancreas, the biliary system, and other cells in the body, like the stomach, the colon, the uterus, and salivary glands. The normal level is less than 37 units per milliliter. It's measured using a monoclonal antibody. And of all of this, we still don't know what it does, but it probably, like I said, it acts as a sign on the cell to allow cells to recognize each other and allow potentially some signaling between cells. But the true biological function still remains unknown. It's the most extensively studied biomarker for pancreas cancer, but however, recognized very early on that it was a poor diagnostic marker. Sensitivity is only about 76%, specificity is 77%, and later on in the talk, we'll talk about what that all means. It's elevated in 73% of bile duct cancers or cholangiocarcinomas. It's elevated in 42% of stomach cancers and elevated in 22% of liver cancers, hepatomas. More importantly, it's elevated in benign causes of bile duct obstruction, like a gallstone. And interestingly enough, it can be markedly elevated in patients that drink black tea. So if you're looking at this as your gold standard biomarker, the problem is that it's a biomarker of who knows what. And more importantly, like we said earlier, patients who have Lewis null blood types don't even produce CA19-9. So they could certainly have cancer and never have a CA19-9 that's detectable. However, if you combine this with other tumor markers, it might increase its clinical utility. So what about where things stood in 2018? And a large group of physicians in partnership with the National Cancer Institute, Pancreatic Cancer Action Network, the Kenner Family Research Fund, they convened a large workshop on biomarkers in 2018. They set a minimum bar for an effective biomarker as a test that had a sensitivity that was high and a specificity of at least 99%. And as of the publication in Pancreas in 2018, there were no biomarkers that were ready for clinical use. So what's available currently, or potentially soon to be available? As you can see there, it's a rehash of what we talked about earlier. There are proteins. There are proteins combined with CA19-9. There's various protein signature panels. There's microRNAs, RNAs that are longer than that. There's circulating tumor RNA and DNA, circulating tumor cells, metabolites, and mixed panels. And we'll kind of quickly breeze through all of these. These are basically all the different things that have been looked at to try to detect pancreas cancer early. And as you can see here, there's a whole host of things that can be detected in the serum of patients for diagnosis of pancreas cancer. I'll certainly draw your attention to a few of these, especially those adhesion molecules on the bottom, ICAM1 and CCAM1. They're actually very, very helpful potentially. And then there's various cytokines and glycoproteins. There's also RNA, as we talked about, biomarkers that have been implicated in the diagnosis of pancreas cancer, and there's a whole host of those. Again, there's also other things that can be useful. As we said, there's exosomes and circulating tumor DNA and circulating tumor cells. So what are the considerations? I mean, there's obviously a whole bunch of things you can test for. The question is, what can you test for, and should you test for anything? The problem with pancreas cancer is that it's molecularly diverse. As such, there's probably no one single test that's going to be useful because, again, it's molecularly diverse. You obviously are testing a tumor that's got all kinds of things that could be wrong with it, both on the machinery level, at the cellular level, or potentially at a higher level. So one single test is probably not going to be useful, but a marker panel is probably going to be more favored because it's more likely to be accurate and robust. As far as a physician goes, they would really want something to be binary, that is present in cancer, but not present in a healthy patient. That would be great. And you also don't want a coexisting condition to be a confounding variable. So something like diabetes or obstructive jaundice, which is common in patients that have pancreas cancer, you don't want that to mess up your biomarker result. And these are some of the tests that are coming out or already out. They're called multi-cancer early detection tests. There's a whole bunch of companies listed here. It's a burgeoning and an amazing field. And we're kind of just, again, at the very, very beginning of these things. And as you can see, there's a lot of these tests are good for pancreas, but they're also potentially useful for a lot of other targeted cancers. 3 of these tests are commercially available now, and 3 are pretty close. None are covered by insurance. None are FDA approved yet, but they're certainly CLIA approved. And what does that mean? It means that they actually can be ordered by a physician. What's available now is a test called GRAIL by Gallery. There's Exact Sciences CancerSeek, and then there's the one test. In the pipeline, there's Singlera Genomics Panseer, Burning Rock Oversee, and RMDM Diagnostics Pantum Detect. And these are multi-cancer early detection tests. And again, it goes back to what we said earlier. There's lots of stuff that's floating in blood, and these tests are aimed to find some of those markers. And again, these markers all can detect various different cancers, not just pancreas cancer. And again, we're just now beginning to understand kind of where we are. I'll kind of breeze past a little bit of this. Dr. Suchestan Campbell, later on in the talk, will talk in more detail about GRAIL. But I just wanted to spend a couple of seconds looking at this slide. And as you can see there, these are all the tests that GRAIL can detect. So when you send a GRAIL test as a clinician, you're going to get a report that kind of helps you, hopefully, figure out what the patient might have. And I put the magnifying glass there around pancreas. You can kind of see there, on the left, it shows you sensitivity from 0 to 100%. And this test is 83.7% sensitive for pancreas cancer. But again, the devil's in the details as usual. It's, again, sensitive, but sensitive based on stage. So as you can see there, stage 1 cancers, a little bit less sensitive versus more advanced stage cancers, a little bit more sensitive. And then I'm going to skip over this because this is data that's going to be covered very, very shortly. We'll cover a little bit more about Immunovia, which is they've set out a test called IMRAE, and again, this will be covered later on in the talk. But basically, they're looking at antibodies, and more importantly, these are antibodies that are combined with CA19-9 in a panel, again, looking specifically for pancreas cancer, and I'll skip over all of that. There are some urine-based biomarkers, and as you can see here, there are a number of different things in the urine that could potentially be checked out. And Nisinen and their group published a study of 82 patients in 2019 that looked at volatile organic compounds in urine. And that was looking at, again, in patients who had no symptoms, they did a urine test, and could they detect pancreas cancer? And the sensitivity and specificity was about 80% for pancreas cancer. They're pretty good, but certainly not fantastic. This study and this whole entire enterprise drew a lot of attention in the news and on the internet because it used worms. In 2015, Hirotsu et al. Demonstrated that the nematode, as you can see there, C. elegans, and you can see a picture of what the little worm looks like, was strikingly attracted to the urine of cancer patients, but completely avoided the urine of healthy patients. And presumably this is due to the worm smelling these volatile organic compounds in urine. And the worms were found to be attracted, again, to patients' urine that contained cancer bugs. So we don't really know if that was true or not, or is true, but presumably that is. So these little worms were acting like bloodhounds, and it was concentration dependent. This entire concept formed the basis of a urine test that is now being directly marketed to consumers in Japan for about $500. The test is called N-Nose plus Pancreas. It's been sold in Japan since November of 22. And does it even work? And the answer is yeah, it does. In 2021, Kobayashi et al.'s group published a trial of 441 patients from Saitama University Hospital. The sensitivity of N-Nose for pancreas cancer was 87.5%. Specificity was kind of on the low side at 60%. But stage 2 pancreas cancer patients had a sensitivity of 93%, and jaundice had no impact on testing whatsoever. And further research by Kobe et al. In 2020 compared N-Nose to other commercially available biomarkers. And you can kind of see there where N-Nose kind of fits. It's kind of at the top end there, and it's kind of really not stage dependent. And they compared their tests to lots of available other tests that are out there, including GRAIL. And N-Nose, the little worms, seem to have been very accurate. So again, food for thought. This is something that's currently being directly sold with commercials, direct-to-patient advertising in Japan right now. What about stool tests? You would think that would be an easy thing. There's lots of things that we test in stool for patients. There's really only one thing that's been looked at in any kind of prospective way, and that's the detection of this protein, ADNAB9. And that was done in a small trial, and they found sensitivity of about 80% and specificity of 87% for the detection of pancreas cancer. But What about breath? You would think, again, and something that might be useful. It's very easy to get breath. You just kind of collect the patient's breath. And will that be able to detect pancreas cancer? Well, it turns out the answer is yeah. And this is being looked at in England predominantly. Mark Herr's group published a pilot study in the British Journal of Surgery in 2018. And they measured, again, these volatile organic compounds in 868 patients. And they found pretty high sensitivity, not so great specificity. And currently, this is being studied in a much larger study at Imperial College of London. So we'll see where that lands. So what are the biomarker clinical uses in 2023? Obviously, I've overwhelmed you with everything that can be done. What exactly should be done presently in April of 2023? You know, where do things stand? So if you potentially develop the test, where would it be helpful? Well, it would be helpful in differential diagnosis, right? A patient walks in with vague symptoms, well, you do this blood test, and then the blood test could be done for all these biomarkers you see there on the right, and it can help the doctor say, well, it is or is not pancreas cancer. If a patient has pancreas cancer, well, potentially, instead of doing CAT scans a bunch, you could do blood tests, and the blood test can tell you whether the tumor is getting better or getting worse. But for our purposes tonight, we're looking at using blood tests for early detection and screening. That's probably the area where it's going to be the most impactful. So really what we're trying to do is we're trying to distill this general population model. So like everybody who walks into the office who thinks they might or might not have pancreas cancer. What I do, and we do this every Wednesday morning in Pancreas Clinic, is we try to define of that general population, who's at the highest risk. And that goes back to what we talked about earlier. If you have high-risk individuals, that's the group you really should be targeting. And if you have these high-risk individuals, but they do not have pancreas cancer, you want to then say, okay, well, we plug them into that third box. You're kind of doing longitudinal screening and you're using complementary tests. Well, then hopefully you'll find pancreas cancer with some imaging study in the patients that have a positive blood test or a positive urine test or positive stool test. Again, you're using the test, the biomarker test, as a gateway from this large group of patients that doesn't have pancreas cancer to who you should then test with more invasive protocols. And again, just kind of show you in a little bit more graphic way, as you can see there's this huge population, right? Patients who are on the right side, more elderly, and patients that are on the left side, younger. All those little green patients there in that big box are the patients that actually have cancer. So you want to then take all the patients there in that big box and kind of funnel them into risk categories, right? So do they have familial risk? Do they have genetic syndromes? Do they have cysts in the pancreas or some other unknown thing? And that kind of then says, okay, that's the group of patients we really should be looking at. Okay, fantastic. Now we should say, okay, if that's the group, who do we test? How do we test? And then we do all this testing. And then you're funneling them down little by little by little using tailored imaging, various other tests. And eventually you're coming down to, at the very, very bottom, patients who are diagnosed at an earlier stage, who are potentially patients who you can operate on and potentially cure. So what are the guidelines currently in 2023? Both the American Gastroenterologic Association, the AGA, and the ASGE, the Society of GI Endoscopy, have published guidelines for pancreas cancer screening. And the conclusion of both is that screening, in fact, has at least moderate benefit and certainly has no harms in appropriately selected patients. And it's clear that pancreas cancer is best done by dedicated high-risk surveillance programs with significant experience in pancreas cancer management. And we certainly thank the National Pancreas Foundation for helping to highlight institutions that have this vast experience. So what do the guidelines say? And there are these two guidelines, like I said, published in 2020 and 2022. Screen all patients who have at least 2 first-degree relatives with pancreas cancer history. Genetic conditions that increase risk, and if they have any of those genetic abnormalities, they should certainly be screened. You should start screening as early as the age of 35, and that's based largely on genetic conditions, because again, when some of these genetic conditions, we potentially can start screening at a little bit later age. You should use endoscopic ultrasonography, as we talked about earlier, and MRI. They should be combined every 12 months. The ASG says, in fact, that you should alternate endoscopic ultrasound and MRI, but you should start with endoscopic ultrasound as your initial screening test. And when the patients get to a point that treatment is going to be too difficult for them, for example, they can't tolerate surgery, that's when you stop. Otherwise, there is no endpoint. These patients, if they're completely healthy at the age of 80 or 85, and otherwise could undergo some curative treatment, they should undergo the curative treatment, and they should continue to be enrolled in a surveillance program. So what are the pitfalls? Why is it that we are not just simply doing this for everybody? Well, it's invasive, it's morbid, it's complicated, it's expensive. These are all the diagnostic dilemmas that we kind of cross with patients every day. The subsequent diagnostic odyssey could be challenging, it could be unclear, it could be variable. What tests do you use for patients? How often? How long? And what happens? Certainly we see this with Cologuard all the time for colon cancer. What happens if you have a positive test, but you can't find anything? That's a real issue. You really want to avoid what that cartoon is showing on the right there, that your patient has 6 months to live, but if we treat them really aggressively, we can make that 6-month period seem a heck of a lot longer. What about stress? We shouldn't discount stress. Breitkopf's group published the results of a survey of 378 patients in high-risk pancreas cancer surveillance program at Mayo. They published it in 2012. 54% will resign to the fact that they were likely to get pancreas cancer anyway. And 47% have frequent thoughts about this, and the thoughts affected mood. Only 1 in 5, pretty amazing that it's only 1 in 5, they weren't worried at all. They knew everyone in their family died of pancreas cancer, but didn't bother them at all, didn't faze them. So those are the eternal optimists in the group. The cost, and this we always have to keep in mind in 2023, cost. The market size value in 2023 is currently estimated to be about $76 billion. Worldwide revenue forecast by 2030 is $181 billion, and 44% of that revenue share is seen here in North America. Keep this in mind. If only 50% of those over 50 years old were to be tested in this fashion, this could likely bankrupt Medicare completely. This is just one disease. There wouldn't be any money left over for anything else for a Medicare patient to actually spend on. And we always need to keep in mind, and the National Pancreas Foundation has certainly done a very good job of this, healthcare disparity. This process should be designed to address compelling needs of everyone, especially those who are most vulnerable and least prepared to gain access. So you certainly need to keep in mind low-income patients, uninsured patients, medically underserved patients, or geographically and socioculturally remote patients. If you have a positive test, don't forget, those patients then need to undergo diagnostic testing. Can they afford to do it? Is it easy for them to do it? Is it even something that's offered in their community? So you don't want to certainly have a positive test and no way to go any further in certain patient populations. Is it cost effective? Tabazzoli has been looking at this for quite some time. Their group published a cost model to find the maximum price of a multi-cancer early detection test to meet a given willingness to pay. The MCED test shifted cancer diagnoses to an earlier stage with a 53% reduction in stage 4 diagnoses. If you added an MCED test, it decreased per cancer treatment costs substantially. And if you said the willingness to pay threshold was about $100,000 per quality adjusted life year gain, the potential value-based price of an MCED test was estimated at about $1,100, or in this case, $1,200. More importantly, if patients were obese or had a smoking history, it was even more cost-effective. So as you can imagine, why is it cost-effective? Well, you're moving patients from advanced disease with very expensive treatment modalities, and you're shifting them to earlier stage. And this graphic kind of shows you that the test is cost-effective across the board, but even substantially more cost-effective in patients that are obese or have smoking histories, more likely to benefit from the test. So this was a large trial called CAPS. It was a trial led out of Hopkins, and it's still ongoing. Lots of important data has been gleaned from the trial. And it's a trial of high-risk surveillance patients. This was published in 2022, and it showed that screening definitely works. This was presented at our national meeting last year, Digestive Disease Week. And as you can see there on the left, that would be patients who were in the surveillance program, and you found lots and lots of patients at early stage disease in a program like that. On the right, that's patients who were not in the program, and you found lots and lots of patients in stage 4 disease where you couldn't do anything about it. So you really want to be on that top blue line, which is patients who are having pancreas cancer detected at an early stage in a screening program. But what other important lesson was learned from this trial? Diagnostic testing absolutely needs to be improved. And Overbeek published in Gastroenterology in 2022 the results of a high-risk surveillance program of 2,500 patients in 16 centers in 7 countries. And surveillance was standard. It included endoscopic ultrasound combined with MRI every year. Of that large number of patients, of that 2,500 number of patients, 28 of those, or 1%, developed neoplastic progression during a median follow-up of 29 months. Interesting enough, but more importantly, 46% of that group developed a new lesion within 11 months following a negative evaluation. So they were in the trial, they had a negative scan, 11 months later, they had advanced disease potentially. And 77%, as you can see there, these new lesions have progressed outside of the pancreas. Again, advanced disease. So that's a real problem potentially that we haven't yet addressed. And that goes back to what we talked about earlier with artificial intelligence. You need some better tests. The tests are good, but they're not perfect. And you potentially may have to shorten the interval between scans. 12 months may be a little bit too long. And the authors concluded that either more sensitive diagnostic tools or potentially, as I said, a different management strategy is needed. So the conclusion of my part of the talk is, again, perfect test would be a simple, inexpensive, and safe sample collection, whatever that sample ultimately is thought to be, whether it's blood, urine, saliva, breath. It's got to be sensitive to cancer at an earlier stage and symptomatic presentation yielding earlier detection. High specificity, you really don't want to detect things that really aren't present, and you really want to avoid unnecessary workups. It has to be acceptable and satisfactory to both the provider and the asymptomatic patient. You can't have a screening test that's so onerous, so expensive, so difficult to do, nobody wants to do it. It's got to be clinically valid in the population that you're intending to use it in. And more importantly, it's got to kind of work. It's got to be complementary to what's currently established for prevention and screening. The perfect surveillance process would be, again, identifying a high-risk population in a better way, utilizing these biomarkers as gatekeepers to more invasive and diagnostic and cumbersome testing, potentially saliva in the primary care doctor's office. That would be great, right? Patient goes to the primary care doctor, spits in a cup, test gets done, and they're told whether or not they're at risk for pancreas cancer, and then they're referred to a high-risk program for more diagnostic testing. And like we said earlier, potentially artificial intelligence will be that ability to make diagnostic testing better. We want earlier stage detection of cancers, and obviously the goal here is to cure and eradicate pancreatic cancer. So just in a nutshell, we're kind of almost there. I really think that this whole idea is going to be a game changer, is already a game changer in the field, and we are almost there. We are this close to getting something that's going to be clinically valuable to the average patient who is at increased risk of pancreatic cancer. So I'll stop there, and we'll turn the talk over to Dr. Lara Sucheston-Campbell, and she'll go over some of the very specific details about how exactly this all came about and where we are in the lab. Prior to joining Immunovia as the Vice President of Clinical and Medical Affairs, Dr. Sucheston-Campbell spent over 13 years in academia in the field of genetic and molecular epidemiology. Most recently as a tenured associate professor of pharmaceutical sciences and veterinary biosciences at the Ohio State University and the director of the Mathematical Biosciences Institute. During her time in academia, she successfully secured millions of dollars in NIH, National Institute of Health, and Department of Defense funding, and she served as the principal investigator of both R, U, and P-level funded grants to develop consortia and run existing consortiums focused on identifying, quantifying, and characterizing the role of genomics and epidemiology in cancer susceptibility and survival outcomes. This work resulted in international scientific presentations and over 130 peer-reviewed publications, and the funding was used to train over a dozen PhD and postdoctoral fellows. She also holds a degree in genetic counseling with a focus on hereditary oncology. Thanks for joining us, Dr. Sucheston-Campbell, and I will turn the talk over to you, and you can wow us with all this futureness.
Dr. Agresti, that was a tour de force, and it's going to be a hard act to follow. The presentation I'm going to give you today, I'm going to wear my genetic counseling hat and my statistic hat. Okay, I'm hoping everyone can see this, and I assume I'll be stopped if you can't. So we'll go ahead and go forward. And I'm going to jump off a little bit where Dr. Agresti left off, because he established such a fantastic background for us to go forward. So I'm going to use this time that we have together to go over some of the tests that he set us up to talk about. And I want to talk about this conversation is possibly to a little bit more of the patient focused out there. So this is maybe what you can think about when you see information about tests. So what does it mean to you when you see information that comes out about tests, and whether it's in the news or whether you see a blurb on a science article. So let's just take a little step back about our blood-based assays as just a review. So we're going to talk about liquid biopsies, or we're going to talk about kind of what's in a drop or what's in a tube. So a liquid biopsy, is, as Dr. Agresti said, is a test on a sample of blood to look for cancer cells from a tumor that are circulating the blood, or pieces of DNA from tumor cells that are in the blood. And these can be circulating tumor DNA. This can be methylation, proteins, metabolites, exosomes. There's a whole lot of information that is contained in our blood, and we can see down here this blood sample that is useful for informing us about what's happening in our body. And that's due to natural processes that normally occur, so cell death that's happening as it should, or processes that maybe shouldn't be occurring, that's with a tumor and shedding. And I want to talk about metrics that we're going to use around all of these tests we see on the market. And there's 4 questions that we can ask ourselves every single time about a test. So the first 2 are sensitivity and specificity. And I think everybody heard maybe Dr. Agresti talk about those. And just simply put, those are, how often is my test right? And how often is my test wrong? So when we have a test, how often is it really picking up folks with cancer that have cancer? And then how many healthy people are correctly identified as not having cancer? So how good is it saying you don't have cancer, you're doing fine? The second thing I get as a genetic counselor sitting in the room, and as a patient, I want to know, I have a positive result. How likely am I to have cancer? How likely is this to be right? Or I have a negative result. How sure are you that I'm going to be cancer-free? So what I'm going to spend the next few minutes doing, and I'm going to try to kind of move through quickly because I want to be sure there's time for questions, is I want to march through the tests that are currently available, and I want to talk about these metrics so that to help you navigate the system that's kind of out there currently. So we're going to start with the one we see a lot in the news, which are Galleri, which is a multi-cancer early detection test. And we can see how this works as we move from left to right. We saw that tube of blood to start, and blood's collected, and then particular information is isolated. And Galleri uses something called methylation. And I like to think about methylation as fingerprints. So fingerprints are unique, and they're specific to people. So we can kind of think about that with cancer and tissues. Methylation and tissue and cancers have unique fingerprints, and that's what this assay is relying on. And the signal is detected. Some statistics are used to separate that out from normal cells. And then we can say, okay, well, these fingerprints look like they go with this particular cancer. These look like they go with this, or no signal is detected. And that's this workflow that we see here is pretty common. I just want to draw your attention to the fact that they're using this fingerprint idea. Right, so let's talk about those questions I promised you that we would answer. So I said that we would talk about the sensitivity and specificity. So how often is the test right and how often is the test wrong? We're going to talk about 2 studies, one that was first published, and down there is the reference. And the test, we know that has a 51% sensitivity and a 99.5% specificity. So the test is right about half the time and wrong about half the time across all stages. The specificity, though, is incredibly high. So that means they're quite sure if the test comes back negative, it's actually negative. When I'm thinking about being a genetic counselor, and I'm thinking about when we're concerned about pancreatic cancer and folks at risk for pancreatic cancer, they're at risk for a very particular set of cancers, and these are those listed here: breast, colon, ovarian, melanomas. And we can look at the sensitivity and specificity sitting there. And so we can see that Galleri detects 51% all stage and about 1 in 4 early stage cancers. And I put along the bottom the composition of so we can see across all races and ethnicities of the test. So this was the first study that Galleri published, and they did a larger one this summer. And here we can ask the question, when I think about the positive predictive value and the negative predictive value, what is it when I have a positive test or a negative test? What's the chance it's actually if it's actually true positive or true negative? So we see about 1 in 3 patients with cancer, cancer signal detected, had cancer. They started out with about 6,000 patients. We see that 90 patients had a cancer signal detected, 55 were at additional risk, 35 had no additional risk, and we moved down from there. So that means that there's about a 40% positive predictive value. So a 40% positive predictive value means that if you're sitting in a room with a positive result and somebody else is sitting in a room with a positive result, about one of you, a little bit less, is going to have an actual true positive. So we're gonna move on from here to another test we want to talk about, which is CancerSeek. So CancerSeek is in development, and this was an exciting science paper that was published in 2018. And this uses a different approach. It's a multi-cancer early detection test. It uses various genes and proteins. So it's different than the fingerprint test. So we can start up at the top left, and we can see that it uses about 16 different genes. It combines them with some proteins. We get a score. We add some additional information for more proteins, and we add about an individual's sex, if they're born male or female. We think about where that might be located, and we end up with a cancer prediction. So this is also across multiple cancers. We can see those listed here. And again, just like with the multi-cancer early detection test with GRAIL, these are cancers that many of them don't have screening. So we know things like, for example, for liver or esophageal. The test included most equally divided between male and female. We see that a majority of individuals were Caucasian, non-Hispanic, and we see that the distribution, because this is a pancreatic talk, we see a lot of folks were stage 2. We have a few at 1 and a few at 3 across about 800 controls of what we think are individuals that are reasonably healthy. So let's see, when we think about the questions I promised you we would answer, how often is the test right and how often is the test wrong? So we can see how often the test is right and wrong on the left-hand side. So all of those are how well are we doing at finding this. So if we go to the bar that finds the pancreas cancer, we can see that sits at about 72%, and that falls between 60 and 80% confidence. I'm 95% sure it's going to fall between 60 and 80%. So, and we're 99% specificity. So I'm 99% sure if that comes back negative, then that test is actually negative. And Dr. Lugresti made a really great point about the stages, and the devil is in the detail. If we look, we can see, gosh, as the stage moves up, we're much better at finding it. And that makes sense when we think about blood assays. It makes sense, gosh, when we think about any type of scanning. The tumor's larger. It theoretically, in most cases, would be shedding more. We'll be able to find more material in the blood. We'll be able to see it easier. The trick is to find it at an earlier stage. Here we can see it's more challenging to find it at an earlier stage. The exciting thing about CancerSeek is the combination of the genes and proteins, and that's the appealing thing about it at this time. So the third one I want to talk about is biological dynamics, and that's just a recent laboratory developed test that came out. And this uses something that's yet another blood product. It continually, as a scientist, amazes me the information we're able to extract from the blood. So this uses something called extracellular vesicles. They're little particles released by tumors into the bloodstream, and we think they might be involved in communication. And that information in these extracellular vesicles, we think that holds proteins, and we think if we can catch them, we'll get information about the tumor. And they're testing pancreatic, ovarian, and bladder. And you notice this workflow. I don't really need to go in and dive into the details, but it looks a lot like the other workflows, right? Gosh, we're going to pick some biomarkers. We're going to see if we can make them work. We're going to test them, and we're going to test them again. And so we want to look at how are they doing in pancreatic, ovarian, and bladder cancer. So how is our sensitivity and specificity? How often are we right? How often are we wrong? So here the sample size is a bit smaller than what we saw. So previously we've seen things in the thousands, right? In CancerSeek is in the thousands, and GRAIL had thousands of, 6,000 patients in a paper they presented this summer. So we see in stage 1 and 2, we see again, a little bit of a difference in detecting. And we see here that the sensitivity of the pancreatic cancer detection is quite good, and it sits at about 95%. And we're 95% sure that will be about 85 to 98% sensitivity. And again, we're very sure at 99% that we can just say no for that. But I want to actually move forward to talk about single early detection tests. Because when folks come to visit genetic counselors in a high-risk clinic, where they come to visit Dr. Lagresti, they're in a different place than maybe the general population that are over 50. They're at risk of developing hereditary or familial pancreatic cancer. And let's just be sure we have a good definition. And Dr. Lagresti did a great job, of course, of marching through what that meant and who could screen. But just so we're all on the same page. On the left-hand side, we see the general population risk sitting at about 1%. And then we can see all these cancers to the side. I don't have to march through any of these. We can see that everyone who has one of these changes in these genes, whether that's a BRCA gene or ATM or PALB2, has an increased risk of having cancer, of pancreatic cancer. Or there are first-degree relatives, or more than one first-degree relative with pancreatic cancer. So, and we can see that there are two tests that, we can see that there are a few tests that I want to talk about today. One was discussed recently and is very new to the market, and that's with ClearNote Genomics. And they use a methylation-based approach. This is, again, remember I talked about the fingerprint idea. And again, the question always is important about how often is a test right and how often is a test wrong. And so we can see the sensitivity and specificity is there. That sits at 64%. It's very good at saying no. Less sensitive though. And then I said I would tell you, well, if I have a positive result, how good are we at saying, yeah, I'm quite sure that that's right. That positive predictive value sits exactly or almost exactly where a Grail's was. So it sits at about 40%. So if someone has a positive result, they're going to sit in a room with another person with a positive result, and we can say, well, one of you most likely indeed has a true positive. This was an abstract, and I'm sure there'll be more data to come. As Dr. Lagresti mentioned, I'm from Unovia, so I want to spend a little bit more time talking about that, about our test, which is the MRAY PanCan-D test. It's a laboratory-developed test for the detection of pancreatic cancer. And so unlike relying on the idea that, okay, we know the tumor is present and is shedding or has a fingerprint or is using material to communicate, and that's what we want to grab, we're using these protein biomarkers and using a combination of them, as we talked about earlier, a bit of this idea of using AI, this more effective way to combine information so that the sum of the parts is greater than the whole. And these are the markers that we're using to find these or to detect these early cancers. And one of them may pop out to you immediately, and that's CA19-9. But you'll notice that's not the only one. We have these other markers that buttress this information so that together we have a more informative picture of what's happening. And we can look and see that those are roughly involved in inflammation, metabolism, tissue and damage repair, or they're tumor associated. And we had the great privilege, like all these other tests, of standing on the backs of giants who's researched this information for decades. So this is the clinical validation study process. So this is the pull back behind the curtain, which is a long process. So it starts with this commercial test model where we're evaluating the markers one by one. We're starting to validating them, and then we're validating them, the final locked signature in another set. So this is a 3-step process across independent samples and multiple studies. And this is with our wonderful collaborators highlighted on the left. And there's a couple of things I want to highlight here. Is that our controls, importantly, while they were healthy, they were also individuals at high risk for developing familial or pancreatic hereditary cancer. And so we can see here that we can see the race and age and sex distribution But that's really important. So we don't just compare to individuals that are only healthy. This again is very much like everyone else's workflow. The patient serum is applied to a microarray. It's scanned with a fluorescent scanner. We have an algorithm and we have a report. So what does this report look like? We can see that the serum is classified as high risk for pancreatic. It's classified as it's either classified as being low risk, borderline, or the test is not performed. So these have very straightforward or easy to interpret test results. So there's 4 possible results listed, and we can see those on the side. So here's the report has a very clear result. So it's either it'll say negative, borderline, or high. There'll be an interpretation that's clear for the patient. Next steps. So this is this conversation that we recommend that you have with your provider about the test. This has the specific information, the limitations, and then there's an additional page with more information. And promise the sensitivity and specificity and the positive and negative predictive value. So our sensitivity sits at 91% for stages 1 through 4, and just slightly below that for stages 1 and 2. So we had a bit of a drop, but those are fairly comparable. So we can say that 17 out of 20 pancreatic cancers were correctly identified, both early and late stage. Our specificity sits at 98%, and our positive predictive value sits at 64%. So instead of 1 out of every 2 people in a room saying, okay, that's going to be positive, we can say that sits out of 2 out of every 3 people. And the negative predictive value sitting at 99%. So these are the blood-based assays, what's in a tube. We've seen that blood contains so much useful information, whether that's the fingerprints and the methylation, whether that's the exosomes, whether that's the protein biomarkers, and that combination, or whether that's the combinations of the genes and proteins. And then so those will, as we advance forward, combinations like that will become more and more informative for ruling in and importantly ruling out cancer diagnoses. And as Dr. Agresti said, this test development is important and the implementation needs to be inclusive in both composition and study design. So lastly, questions you might want to ask yourself if a patient at this whirlwind tour, are you getting testing because of a concern for one cancer or many? How good is a test for what you want? If I get a positive result, what does that mean? Are you tolerant of additional evaluation to find the answer, time and uncertainty? If I get a negative result, what does that mean for me? And how does this fit into the burden that you're already carrying around for screening? And with that, I want to go ahead and stop sharing my screen and give folks time to ask some questions.
Absolutely fantastic. See, this is where all the science comes in. You know, we're just the guys at the bedside. That's where all the important stuff comes from. So we absolutely, positively depend on Dr. Suchestin Campbell and her colleagues. So this way we can apply some of this stuff from the bench to the bedside.
That's why they call it bedside.
Thank you. And you did great with all that scratchy throat stuff.
Sorry.
So I just wanted to kind of bring a little bit of real world flavor to, you know, what we do again every Wednesday morning in my office. I think that first of all, the fact that there is a possibility for screening, I think, is probably the most important thing that we can send home as a take-home message tonight. Again, it shows that with all this work of giants that you mentioned, I think we really got to the point now that there really might be some kind of test that can be offered to patients. But stepping back for a second, and I really think that's an important concept for people in the audience to understand, this certainly is not something that I think the average doctor should be dabbling in. You know, I really think it's, as we saw in this field, in this world, it's very complicated. And this is not even for people that do this every single day of the week. We're realizing that there's many nuanced approach to this, and this is not something that the primary care doctor wants to really dabble in or should want to dabble in. And again, this goes back home to why we talked about centers of excellence. This is something that really should be done by docs who are doing this every single day of the week. But again, I think it's just amazing that we're finally at this point.
And I wanted to there are some questions in the chat. One, are there tests for pancreatic cancer recurrence?
Yeah, listen, at the end of the day, I think you know, we still can't discount what is available currently, right? And how do we know whether someone who had pancreatic cancer was resected, they were told they were cured? How do we know that they truly are cured? I mean, clearly there's always this 5-year window that we look at, and we are very, very vigilant in following patients carefully. Going back to what we talked about earlier, these tests, these biomarker tests might play a role here, but we still have to keep in mind what is currently standard of care in 2023, and that's imaging. We are still, hopefully we will gravitate away from this in the near and distant future. We're still heavily dependent on imaging, as we talked about CAT scan, MRI, endoscopic ultrasound, to guide us to whether or not a patient has pancreatic cancer recurrence. And we're still, again, we are really sensitive to this in a very heightened way for those first 5 years after a patient is deemed, quote, cured. We certainly don't see a lot of cures in this field, and it's kind of a little depressing, but hopefully we're going to change all that. But when the patients that are potentially resected and cured, we're very, very vigilant with imaging tests. And hopefully one day there will be something a little easier for patients that includes some of these biomarkers. So then there's a couple of other questions that came up here. We will say this one here is something that comes up not infrequently. Does the IMRAY test work in a Lewis negative patient?
Yeah, so let me answer that. So right now, any test, so that would include CancerSeek, the exosome test I mentioned, our test that depends on CA19-9 will be less powerful because it depends on that biomarker. We do not use our test with Lewis null patients because of that. The publication did use those data, and it did include that. We will not. We are actively working on version 2.0, which will absolutely be able to include that information. We'll be able to include those patients. That is our research priority #1 at this point in time.
Yeah, I mean, certainly we see that in a lot of our patients that we've screened with the test. We are getting some reports back that say we can't do the test. So patients come away going, what the heck does that mean? And we have to explain to them that, in fact, 6 to 22% of Caucasians don't, in fact, have the ability to have the test.
And it's a higher proportion in other populations. And so this is something that's why this is an incredibly big priority for us.
And again, we still fall back to what's still considered standard of care, which is endoscopic ultrasound and MRI. Another question, and again, this goes back to CAT scanning. If you see on a CAT scan peripancreatic fat stranding around the pancreas, does it point to a cancerous tumor? And that's, again, one of those things there that artificial intelligence may be able to help discriminate. Peripancreatic fat stranding is, in fact, one of the features that you see on a CAT scan that could point, in fact, to pancreatic cancer, but it could certainly point to pancreatitis. So again, it's one of those things where if you have a very, very dedicated and good radiologist, theoretically, they might be able to distinguish peripancreatic fat stranding related to cancers versus non-cancers. So again, it's one of those things that's certainly on people's minds and needs to be kept in mind when you're helping to find pancreatic cancer. And going along with that same idea, this question said, I have a cyst on my pancreas head, and I have an MRI and an endoscope done on a rotating basis. Should I be asking for blood marker tests as well? Fantastic question. I think we don't yet know kind of where these biomarkers will fall into the algorithm for patients that have pancreas pathology. And I think that research is currently being undertaken as we speak. Again, these tests are aimed for patients that have nothing in their pancreas theoretically and have no symptoms and have a high-risk condition. And that might include things like pancreatic cysts. So we still don't know where that's going to land. And certainly it's something that is being looked at. And I think potentially that will be very helpful. But currently, if you have a cyst in your pancreas, the current thing that should be done is exactly what's being done, MRI and endoscopic ultrasonography for surveillance.
I want to make sure we define hereditary. Hereditary means the individual has a pathogenic or likely pathogenic, so disease-causing mutation in a known pancreatic cancer susceptibility gene, and usually a family history in there, and that they should be receiving follow-up care around that. I hope that answered your question, Hannah.
An important question. What is the cost to the patients for PanCan testing and insurance coverage? Very good question, because honestly, we get that question all the time. The first question they ask is, am I at risk of pancreas cancer? The next question they ask is, how much is this going to cost me? So it's always a tricky situation because patients don't want to necessarily pay $5 copays to come see me. But when you start talking about $1,000 tests, patients start having heart attacks. But I also fall back on, exactly what made the patient come to see me in the first place. Clearly, you can't really sometimes put a price on peace of mind. And I think that's, for me, I think one of the messages I hammer home to patients, when we're talking about peace of mind sometimes. And again, if there's a test that's very useful for a patient, that isn't going to break the bank, and isn't very, very expensive, again, finding cancer at an early stage is cost effective. So for me, if patients can potentially afford this, and obviously the company works with them, companies work with patients all the time to make this more affordable. That's my take home message from that. I really tell them, listen, peace of mind can't be bought.
I do want to ask a question early on, and I'm sorry I didn't get to it first. She had a KRAS mutation and HNF1A. And she said, is that a risk factor? I just want to make sure that when we highlight to patients that there's genetic mutations and that you're born with, and those are called germline, and there's tumor mutations. And if you haven't had genetic testing, you should definitely be sure that you go and see a genetic counselor to get genetic testing to see if you have a mutation. And I appreciate you wrote there that you are adopted and you weren't sure about your family history, but you should consider going to do that. I'm happy to provide a reference for a genetic counselor, et cetera. But when we think about tumor genetics, that's different than the genetics that you're born with. And so to answer your question, HNF1A is not a germ line, it's something you're born with genetics.
And then there's a question here that's interesting because it comes back to CA19-9 again. I have annual CA19-9 readings that fluctuate between 71 and 96 since December of 2020 when I was diagnosed with chronic pancreatitis. My most recent CA19-9 was 84. Are there any known causes for this fluctuation? My latest MRI showed really nothing in my pancreas, no discrete cystic, solid, or enhancing mass. And this, I think, goes back to what we said earlier. CA19-9 by itself is a crummy test. It's good, but it's certainly not great. It's a test, obviously, that was FDA approved a long time ago. It was a test that was the first test. It's certainly very useful as part of a larger panel. But by itself, and it irks me sometimes when docs are ordering these tests and really don't know what to do with them. And again, because of how non-specific of a test it is, it can do these things. It can fluctuate. Again, as we saw earlier in my talk, CA19-9 can elevate if you drink tea. So it's one of those things where it's great if you have pancreatic cancer. We use CA19-9 to assess for metastatic disease. We assess patients for follow-up. But we certainly don't like it to be followed because it doesn't really tell us much. What do you think, Dr. Suchestan Campbell? Do you agree with that?
Yeah. I think it's it fluctuates, and I think the kind of when we think about the challenges in testing it is that we want to find patients that are it can be quite obvious when someone has a CA19-9 in 4,000 or 3 and they're not Lewis law. We know that they're sick or well. But those folks who are in between, those are the patients that we want to find, and we want to be able to use a test to detect.
Yeah. So again, in the end of the day, I think the message here is that there are lots of tests that we could use, but then there's tests that we probably should use. And again, we don't want doctors just willy-nilly testing all kinds of things and hoping to hit the home run. The work is being done now, and this is the kind of work that we should be kind of following. And it looks like the last question here is, I have severe PEI diagnosed recently with a fecal sample. I assume EPI, exocrine pancreas insufficiency. My number, and that's on a fecal elastase, was 68. I was given Creon, and it seems to help slightly. I had a HIDA scan and a CAT scan. Both came back fine. They didn't say anything about pancreatitis. I had an upper endoscopy, and I'm awaiting my results. My blood work shows that my BUN and creatinine ratios are a little high. My grandmother had most of these symptoms that I have, but was never diagnosed. Should I use biomarker testing in this scenario? And that's, again, an important question. Where do you use biomarker testing? Do you use it for patients that have any pancreas issue? Do you use it for patients that have no symptoms at all, or something in between? And is a patient like this, for example, who's concerned that she might have pancreatic cancer, but doesn't have a family history or germline mutations, should she be offered biomarker testing?
That's obviously, so right now our test is designed for folks who have that familial risk, right? And as we expand and as we are able to have a better developed test, we'll be able to address more people at risk with specific risk factors. So Autumn, you have a specific consideration. And so for me to say our test and its intended use fits yours, I can't say that with an honest face. So I have to say, you know, I wouldn't recommend that. And right now, the tests on the market currently don't suit what you have currently happening for you. So they aren't, you don't have what's currently going on, you don't have indications for that. Yeah, that's the
and certainly needs further workup. I mean, no question. I see very commonly patients in pancreas clinic who have EPI, and you wonder, why do they have EPI? Well, there's lots of other things we should be doing that doesn't necessarily include a biomarker test, because pancreatic cancer doesn't necessarily come to mind as the first thing that we need to worry about. But there's lots of other things that need testing. So certainly go to someone who does this all the time.
Oh, I actually did want to circle around about the cost. We have a cost calculator. Sorry, I should have, my apologies, I should have mentioned that. I'm putting it in the chat. Most people do, I put in there also, most people do pay under $200. There's the cost calculator, you can determine it. So if you're more comfortable having, you know, a private monetary calculation, that's, you know, you can do that in your own home.
Great. Looks like we are run out of questions. It is now 8:23. We went a little bit over, but unless there's any additional questions or any additional points to hammer home.
We hope this was useful.
Yeah, hopefully it really was a useful talk, and you guys learned a lot about biomarkers. For me, I think having done this a very long time, this is the first time I'm really optimistic about the future for pancreas cancer detection. And we can certainly thank, you know, pioneers like the Dr. Justin Campbell, who are working really hard to make this go from bench to bedside. And again, I can't hammer it home enough. This, I think, is a big game changer.
And feel free to reach out to both of us. I'm volunteering you too, Dr. Lorgasti.
Sounds good. All right, guys, thanks very much. And you should have this entire talk recorded. It should be posted on YouTube by National Pancreas Foundation shortly. I want to thank all of you for participating in this talk. I think I learned a lot myself, and hopefully you guys learned a lot too. Hopefully you guys have a great evening.
Bye all.